from University of Balochistan warmly welcome all participants in the third session of the first virtual international pharmacy conference of Pakistan. I hope that you all will get maximum benefit and learning from this innovative opportunity of uplifting the profession in our country. Moving toward our session, our guest speaker for this session is Dr. Mansoor Khan. Dear attendees, Dr. Mansoor Khan is currently working as senior clinical pharmacist covering oncology, hematology, BMT at Ministry of National Guard Health Affairs at Jeddah for last 14 years. Respected attendees, he is graduate of Punjab University of Lahore, batch 1999, and then masters in 2005 at Pharmacology and Therapeutics. Respected attendees, Dr. Mansoor Khan served as clinical pharmacist in Shaukat Khanum Cancer Hospital and Research Center. Our speaker joined MNGHA in 2006 and has been working in National Guard since he obtained BPS certification simultaneously in 2010 and 2017. He also established clinical pharmacy services in Princess Noora Oncology Center and other services. I will not take much of time of you moving toward our great speaker. So over to you. Assalamu alaikum.
Walaikum assalam wa rahmatullahi wa barakatuh. Good morning, everyone. Can you see my screen?
Yes, sir. Please.
Yes, sir. Yes, sir.
Okay. So thanks a lot for giving back to pharmacy in Pakistan, for providing me this opportunity to present this talk in this prestigious forum. My talk is actually flying with a theme of innovation in pharmacy, and I'll talk about innovative role of oncology clinical pharmacist. I do not have any disclosure, and that is the hospital. Every one of you are familiar with this hospital, Shaukat Khanum Cancer Hospital and Research Center located in Lahore. That's the hospital where actually I learned what is the meaning of oncology clinical pharmacy. And that's really one of the biggest charity center in Pakistan, which is providing treatment free of cost to many indigent cancer patients in Pakistan and neighboring countries, including Afghanistan. And really need to continue supporting the cause of Shaukat Khanum Cancer Hospital, which has its branches in other cities as well right now, like Peshawar and Karachi. These are my objectives. Oncology care is becoming more and more complex. So definitely that evolves the importance of oncology clinical pharmacists to cater optimal cancer care services to the oncology patients. So we'll define the vital role of the clinical pharmacist in optimizing care of cancer patients. We'll talk about what are the required qualifications and experiences in order to become oncology clinical pharmacist. We'll talk about direct patient care activities and indirect non-clinical activities of the oncology clinical pharmacist. We'll share with you the experience of oncology clinical pharmacy services at my hospital, which is Ministry of National Guard Health Affairs, Jeddah. So why it is really important to be an oncology clinical pharmacist, and why the role of oncology clinical pharmacists have become so much innovative in oncology. This is because of a couple of reasons. Number one, the incidence of cancer is increasing worldwide, partly because of more awareness campaigns, more screening strategies. So estimated number of newly diagnosed cancer patients in the United States this year in 2020 is approximately 1.8 million new cases are going to be diagnosed. And approximately 600,000 people are expected to die from cancer in the United States in 2020. Cancer is the second most common cause of death in the United States, but we have witnessed significant improvement in progression-free survival, overall survival, and overall response rates in cancer patients. That does not only reflect improvement in the treatment strategy, but also reflects improvement in the diagnostic strategies. Now we are at the cutting edge of the diagnostic strategies. We have many prognostic and predictive biomarkers which are helping us in deciding the treatment strategies. We're in the precision medicine era, and that has resulted in significant improvement in survival outcomes in our patients. Oncology-hematology is one of the fastest and largest growing discipline We have seen around 250 drugs and indications approved by United States FDA in past 7 years, which is much more than any other medical discipline. And approval of these medications and indications becomes incorporated in international guidelines such as NCCN guidelines, ASCO, European guidelines. And once these recommendations from the international guidelines are in place, and it becomes the sort of obligation for us in the rest of the world and other institutions to get the same kind of care for our patient. And that that's where the role of innovative role of the oncology clinical pharmacist comes into play, to use the judicious resources in a cost-effective manner in order to provide innovative oncology care to all cancer patients, which is in line with international guidelines. We have seen that expenditures in oncology and supportive care is steadily increasing 7 to 10% every year. This is the data collected by IQVIA. And right now in 2020, we're expected to spend around 150 billion US dollars. By the year 2023, we are expecting to spend around 250 billion US dollars. And the role of the oncology clinical pharmacist is multidimensional. I'll talk about myself as a representative of the role of the oncology clinical pharmacist as an innovative role of the oncology clinical pharmacist. So in a typical day, when I'm preparing for a round, in order to attend a round with the medical oncology or hematology team, so I look at the diagnosis of the patient. When I'm preparing the patient care plan, I look at the assessment and investigation, for example, bone marrow biopsy for leukemia, lymph node biopsy for lymphoma, tissue biopsy for solid tumors. I look at the scan in order to see like what kind of state this patient is in. I look at molecular markers in order to see like what is the prognosis of the patient, and predictive biomarkers, for example, in order to choose what kind of target therapy is more cost effective for these kind of patients. I'm attending rounds with the team. I'm attending tumor board meetings. And this kind of assessment and patient care plans actually help me in participating in decision making when I'm sitting with the medical oncology and hematology physician and medical teams. And around 20 to 30% of the time, we're looking at reviewing chemotherapy protocols and trying to optimize the care of these patients with the selection of the right kind of treatment option for these kind of patients. But around 70 to 80% of the time, actually, we're looking at the supportive care. As I mentioned that there have been more than 250 drugs and indication approved by US FDA. This is significant drug development activity, which comes at the cost of significant toxicities beside the financial toxicity. So obviously it becomes our primary role and innovative role to provide the supportive care in order to minimize the side effects, improve the compliance of the treatment, and improve the overall quality of life and the clinical outcomes. And most of the patients actually, those who try to live longer, like early stage solid tumors, lymphoma, leukemia patient, pediatric oncology patient, they tend to live longer, so they have survivorship issues. So these patients are followed in survivorship programs and surveillance, and the clinical pharmacists have important role to play in these kind of survivorship programs as well. So this slides actually talk about the daily activities of the oncology clinical pharmacist. So we have two kind of major activities. We provide direct patient care to the patients. And for example, we attend medical rounds, we attend tumor board meetings, we attend lymphoma board meeting, bone marrow transplant board meeting. That's what I do actually in my clinical practice. And we educate the patient. That's also a direct patient care activity. And by attending rounds, actually, we're participating in clinical decision making. And of course, as I mentioned, that we provide a supportive care to our patients. We work with other healthcare professionals in a multidisciplinary team fashion in order to write the institutional guidelines. The clinical pharmacists in oncology, they play a very significant and leading role in writing the guidelines. For example, febrile neutropenia guidelines, tumor lysis syndrome prevention and management guidelines. These are primarily authored by oncology clinical pharmacists. We sit in various committees, for example, Pharmacy and Therapeutic Committee, Quality Improvement Committee, in order to improve the safety, efficacy, and the quality of the cancer care. And we significantly contribute in cancer patients, in cancer research in cancer patients. So we're providing education to patients is really important and innovative role of the oncology clinical pharmacist, because we as oncology clinical pharmacists or oncology pharmacists, we try to make sure that we address all the questions of the patient, particularly with regards to the first drug reaction. So, and we try to educate the patient and caregivers about the adverse drug reactions, and tell them ways how to avoid these adverse drug reaction. And by minimizing the adverse drug reaction, we try to improve the tolerability of the cancer regimen, complex anti-cancer regimens. And by reducing the side effect, we definitely reduce the hospitalization and extra costs associated with the hospitalization, and that definitely improve the quality of life of the patient by improving the overall clinical outcomes. We can provide the education to patients near the infusion center, like in Shokat Hanam, there is chemo bay. So always you have like outpatient area, there you have infusion center. So we have outpatient where you can actually go and talk to the patient and counsel them. In Shokat Hanam, we used to give like post-chemotherapy medication to the patient themselves. We used to visit the chemo bay, and that's really good. And I think I would suggest that everybody should be doing the same. The oncology patient pharmacy, when the patient comes for medication and the caregivers, you can educate them over there. And many centers in the world, they have ambulatory care clinics. Like in our hospital, we have lung cancer clinic. We are opening new clinics like BMT clinic, and oral chemotherapy clinic will be open soon. So these clinics actually work side by side with the physician clinic in order to provide education to the patient besides doing other things in the clinic. And around 20 to 30% of patients that receive chemotherapy in the inpatient setting, but around 70% of patients in the inpatient setting, they come actually for the management of the toxicities, for example, febrile neutropenia, pain management, etc. So, and we can provide education to these patients when they're admitted in the hospitals. So that's what I was emphasizing, that we definitely need to provide optimal supportive care to our cancer patients. There are a bunch of things that we have to work on. For example, one of the most key thing and innovative stuff that I do in my patient, I try to recommend prophylaxis, antimicrobial prophylaxis, in order to prevent cancer-related infection. For example, in AML, I try to recommend like antimolar prophylaxis, antiviral prophylaxis. In ALL patient, I try to recommend anti-G's prophylaxis in order to prevent the cancer infections. And for the management of the infections, we try to recommend our antibiotic according to our institutional guidelines and according to our antibiotic. We recommend filgrastim in order to prevent febrile neutropenia in the regimen, which are known to cause febrile neutropenia in more than 20% of patients. We try to make sure that the patients are on optimal chemotherapy-induced nausea vomiting prophylaxis, and they're part of our softwares. We have the chemotherapy library, and we have built in the prophylaxis for chemotherapy-induced nausea and vomiting. We try to make sure that we provide pain management. We try to make sure that there is chemoprotectants prescribed along with the chemotherapy. For example, Mesna has to be prescribed with ifosfamide in order to prevent hemorrhagic cystitis. But nutrition is pretty much our job, and we try to provide palliative care to our patients as well. So now, what is required to be an oncology clinical pharmacy? There are two different tracks. The first track is on job training. Actually, I got this job training in Shokat Hanam Cancer Hospital back in 2000 when I joined Shokat Hanam Cancer Hospital. I got the training and job. And the second track, which we recommend right now, is the residency track. The people need to go for the PGY1 residency. Shokat Hanam, Shifa International in Pakistan, I think they have started residency program, and Shokat Hanam has received ASHP accreditation as well. And I think they are planning to do PGY2, which is specialized residency. And I would recommend to go for this track, PGY1 residency, followed by PGY2 oncology specialized residency. And that definitely 1 year of residency is equivalent to 3 years of on-job training. And this is pretty much recommended because this is providing structured training program. So after the completion of PGY2 residency training program, the practitioners can pursue the advanced specialty certification, which is known as board certification oncology pharmacy, BCOP. This is American board certification in oncology pharmacy. Now let's try to share with you some of the experiences of oncology clinical pharmacies at my hospital, which is King Abdulaziz Medical City, Ministry of National Health Affairs, Jeddah. I joined Ministry of National Health Affairs, Jeddah, in 2006, and there was no existence of oncology clinical pharmacy in my hospital at that point in time, and there was a physician used to prescribe like handwritten prescriptions for the chemotherapy, and I saw like people were prescribing, like for example, capecitabine 27 tablets without having any information about the dose, the protocol, and I slowly got infiltrated into oncology hematology, and it took some time, like 6 months to 1 year, to fully establish in oncology and hematology. At that point in time, there were only 3 oncology wards with 70 inpatients in 2006, but now we have 140 inpatient beds for oncology patients in 2020, and we are expanding more, and we're going to be having 10 oncology hematology wards in coming year. In 2006, I was the only one clinical pharmacist covering all the services. Now we have 6 clinical pharmacists. We have our own PGY2 oncology residency program, and there have been 9 graduates so far from this program. So we have 2 adult hematology clinical pharmacists covering different services of oncology. We have 2 medical oncology clinical pharmacists and 2 pediatric oncology clinical pharmacists. And we are going to hire 1 to 2 more oncology clinical pharmacists in order to extend our services in the ambulatory care setting. So the daily life of oncology clinical pharmacist is pretty much similar to the job description that I provided as the daily activities of the clinical pharmacist. So that's pretty much a reflection of what we do here. So we attend rounds with the oncology team. We attend tumor board meeting. We participate in treatment decision making, and we educate the patient. We educate pharmacists, physicians, nurses, and healthcare professionals. We precept pharmacy interns from various universities around the country. We precept PGY1 and PGY2 residents, and also we precept oncology physician residents and oncology physician fellows. So I'm a regular preceptor of the oncology physician residents and oncology physician fellows. We sit with the multidisciplinary team and we write up the guidelines for the institutions. As I mentioned, we have authored many guidelines, so pharmacists have a leading role in writing these kind of guidelines. We sit in various committees. One of the most important decision-making committee is formulary management committee, for example, pharmacy and therapeutic committee, and we have very significant and leading role in pharmacy and therapeutic committee. We are trying to use the judicious resources in judicious fashion and cost matter. We are conducting clinical researches, and these are some of the examples of the therapeutic intervention that we do. We review chemotherapy protocol. We have software called AREA. So all the chemotherapy protocol prescribed in AREA have to be reviewed and approved by a clinical pharmacist, and then they can be processed to nurses, and nurses can process it to pharmacy. So this review is mandatory. We try to identify and monitor and prevent the adverse-drug reactions, and we try to identify if there is any missing element in the supportive care medication. We try to recommend supportive care medication. For example, chemotherapy-induced nausea, vomiting prevention if it is not optimal. So we try to recommend adding optimal chemotherapy-induced nausea, vomiting prophylaxis according to our institutional guidelines. We recommend the dose adjustment based on the organ function and toxicities. For example, hematological toxicities. We do the TDM for the drugs that is required to be monitored. We do medication reconciliation, and we have a beautiful antimicrobial stewardship program running in the country. Actually, we are the pioneer in initiating the antimicrobial stewardship program in the country, and we have seen the beautiful results of this antimicrobial stewardship program. We have seen significant improvement in our antibiogram. We had resistance issues, so by use of antimicrobial stewardship program and antibiotic de-escalation, we have seen significant improvement in antibiotic resistance. We do recommendation of the cost-effective alternative, and that's the key and innovative element of the oncology clinical pharmacist. As I mentioned, that we do formulary management, and we have a leading role in pharmacy and therapeutic committee. And the formulary management in 2019, our cost-effective recommendation in PNT committee had saved 100 million reals only in 2019. And we are part of the multidisciplinary team. We are a corporate organization, actually. We are part of the multidisciplinary team where we write the drug use policies. We do a lot of medication use evaluations, and sometimes the medication which are the most expensive medication, so we do the MUEs for those medication, and medication which have some safety concerns. We also do the medication use evaluation for those. I'll present an example in a minute. We do a regular class reviews of oncology drugs and periodic oncology formulary review. As I told you, oncology and oncology is the fastest and largest growing discipline. Every month, every week, we see new drug getting approved. So we have to try to make sure that which drugs are most cost effective for formulary. That's an example of the medication use evaluation that we did and a couple of years ago, actually a few years ago, and we published our medication use evaluation in one of the American paper, JQSH. So actually we found like before 2015, factor 7, recombinant factor 7 was one of the most expensive medication on the budget of the Ministry of National Health Affairs. So we tried to do the medication use evaluation, and we found out that hemophilia A and B with inhibitor is the most common indication where the recombinant factor 7 was used. So this MUE had opened our eyes to look for the alternative, cost-effective, cost-saving alternatives, and we found FIBA is one of the cost-saving alternative and is actually much more effective in terms of prevention of bleeding associated with hemophilia A and B with inhibitors, and it really reduces the hospitalization and annual bleeding rates. And by adding FIBA, we saved around 15 to 20 million reals per year, and that is the continuous saving every year. And then we continue to look forward for other cost-saving strategies, so other cost-saving alternatives, and we found out emicizumab in 2019 is much more cost-effective, and it's much more convenient for the patient because it can be given once weekly, once every 2 weeks, or once every 4 weeks, and it's given subcutaneously. Patient does not need to come to the hospital. Patient can self-administer, and it has 1 million real, cost saving per patient per year, and annual bleeding rate associated with the emicizumab is far lesser than FIBA and factor 7. So based on our MUE guidance, which guided us in the formulary management, and we recommended to add emicizumab to the formulary, replacing FIBA and factor 7 for this. There was another cost-saving initiative that we took almost 10 years ago. We recommended respiricase 6 milligram fixed dose strategy for prevention and management of tumor lysis syndrome in adults, and we published our paper in JHOP, one of the US journal, and we found like that 6 milligram fixed dose strategy is effective, and it's saving around 1 million real per year. We have another cost-saving strategy. Chronic myeloid leukemia is treated with tyrosine kinase inhibitor, and the treatment is lifelong. But there had been some kind of treatment-free remission initiative started in North America and Europe, and likewise, we also offer treatment-free remission to our patient, which is a hope. That means that those patients who go into deep molecular remission for at least 2 years, we can stop or discontinue tyrosine kinase inhibitor, and around 50%, 40 to 50% of patients are not going to require continuation or resuming tyrosine kinase inhibitor. So we offered treatment-free remission periods for our patients, and we found out like treatment-free remission was 92% in our patient, which is much more than reported in the literature. And our resident, PGY2 resident, presented this data in HOPA this year, and I was the supervisor of this meeting, and this initiative had 5.8 million real saving, and I would recommend that those patients who have like deep molecular response can offer treatment-free remission period to those patients. This not only minimizes the financial toxicity, but also the physical toxicity burden, and also improve the psychological well-being of the patients. Pertuzumab and pertuzumab can be used in adjuvant setting in HER2-positive breast cancer. Based on the affinity trial, randomized phase 3 trial had shown that the improvement in invasive disease-free survival by using pertuzumab is improved only by 1%, which is not a clinically meaningful outcome. So based on that, we did not recommend using pertuzumab in adjuvant setting in Saudi Arabia, and we do the same actually for Pakistan. And by doing that, I presented this slide last year in Shogathanam Annual Cancer Symposium, we can save around 24 billion reals for 4,250. And another innovative role of the oncology clinical pharmacist is to cut down the cost of the biologicals. The biologicals, they have significant driver in increasing the healthcare costs. So by switching to appropriate biosimilars, we can reduce the cost by 30 to 50%. We published our paper in one of the American journal JQSH, where we published our experience of using filgrastim biosimilar, where we save 60 million. We have added other biosimilars in our formulary, for example, trastuzumab biosimilar, and we have planned to add more biosimilars. And we are resource limited countries, it is Pakistan, in order to have more access of the cancer patient to these biologics. Another innovative role of the oncology clinical pharmacist is to have an
Sir, sorry to interrupt you. Actually, I have to tell you that 5 minutes are remaining for lecture time.
okay. So
Thank you, sir.
another innovative job of the clinical pharmacist is to have hands-on experience in applying the pharmacogenomics in cancer patient, because the pharmacogenomics have predictive and prognostic biomarkers in oncology. For example, I'll give you an example of KRAS mutation analysis in metastatic colorectal cancer patient. I started this in Saudi Arabia, in 2007. Our hospital was the first hospital when we started KRAS mutation. Initially, I was facing resistance from the physician that we are disrupting their practice, but actually what happens that if KRAS is mutant, then the patients are not going to benefit from cetuximab and panitumumab. And in US, around 30 to 40% patients, they have KRAS mutant metastatic colorectal cancer. But when I started KRAS mutation analysis sponsored by the pharmaceutical companies, we were sending it out to Germany and the UK, we found out more than 50 or more than 60% patients, they were actually having KRAS mutation, so they were not candidate for cetuximab and panitumumab. That it does not only save the money, but also provide different lines of treatment option for these kind of patients. Similarly, I'll not go through all of them because of paucity of time. So FLT3 mutation in AML is really important because it has prognostic and predictive biomarker value. It has prognostic value because those AML patients who have FLT3 mutation, they tend to have poor prognosis. They need to be treated with allogeneic stem cell transplantation. And it has predictive biomarker value because there are target therapies for the management of the FLT3 positive AML. For example, using mitostatin frontline setting improve the overall survival from 25 months when you use 7+3 to 75 months when you use 7+3 induction plus mitostatin, and you continue mitostatin in the consolidation and to complete 1 year. We have significant contribution in clinical research. We have published many papers in peer-reviewed journals. Our oncology clinical pharmacists are part of international clinical trials and registries. And we have many projects going on with our pharmacy residents. We have medical university. Their students are doing many research projects under our supervision. And we are publishing and presenting our papers, posters in international conferences and meetings, such as ESHP and WOPA every year. And our residents, they are also presenting the projects in our National Resident Day. And most of the time, they are getting positions, which is a competition with the medical residents. So most of the time, our residents are winning the first prize. So the last slide, we have some challenges in oncology pharmacy practice, as we have seen in increasing incidence of cancer worldwide and increasing number of drug approvals and the shortage of oncology medication. That's really a big challenge. And financial toxicities associated with the cancer treatment, especially with the new biological and target therapies, is really overwhelming. And that really needs the attention of the oncology clinical pharmacists to play their innovative role in optimizing the cancer care to deliver to these patients in a cost-effective manner. And another challenge is that we have limited number of competent oncology clinical pharmacy practitioners, so we encourage more and more people to join oncology clinical pharmacists to serve patients in Pakistan and worldwide. And I would like to conclude that oncology practice is highly evolving field, which necessitates the presence of highly skilled practitioners. Oncology clinical pharmacists, they really need to be innovative in their role, and they need their innovative role is actually to provide supportive care and cancer care to all the patients in a cost-effective manner. And their innovative role in formulary management results in substantial cost reduction and improves the overall clinical outcome and quality of the life of patients. And the oncology clinical pharmacist plays vital role in formulary management and cost. And that's all. Thank you so much.